Good afternoon, students. In the previous topics, we have discussed about hypertensive retinopathy and ROP. So today we'll continue with two important topics: retinal detachment and retinitis pigmentosa. Already we are running short of time, so I'll finish it fast. So first we'll discuss with retinal detachment. So what is retinal detachment? I hope you all remember that generally there is a small potential space between RPE and the neural retina. So when there is separation of neurosensory retina from this retinal pigment epithelium, it is called retinal detachment. So how do you classify retinal detachment? It is mainly of two types, primary and secondary. Primary means it is regmatogenous retinal detachment. It is caused due to break in the retina. Secondary means it is due to an obvious mechanical cause. There are of two types, tractional and exudative. So first we'll deal with primary or regmatogenous retinal detachment. So what do you mean by regma? It is a Greek word meaning break. So the detachment which is associated with a retinal tear or break is called regmatogenous RB. So what are the various predisposing factors for the development of RRB? The main important factor is age. It is more common in individuals with age group of 40 to 60 years. And in males, it is more preponderant when compared to females. And in pathological myopics, 40% increased incidence of RRD is present. And in patients with aphakia and pseudophakia, there is increased incidence of regmatogenous RD when compared to phakics. Next, coming to other important risk factor is retinal degenerations. The various retinal degenerations like lattice degeneration, snail track degeneration, white with and white without degeneration, retinoschisis, all these can add to the occurrence of retinal tear. And another important factor is trauma, senile posterior vitreous detachment, retinal necrosis, and family history of RD. So, with completing the predisposing factors, we will proceed to pathogenesis of RRD. So, the main important factor is first is the occurrence of a retinal tear. So, the predisposing factors, as I already said, they are senile, acute posterior vitreous detachment, predisposing retinal degenerations, aphakia, and trauma. Because of all this, there is occurrence of a retinal break. And the important thing which should be present in this RRD is that the vitreous should be degenerated and liquid-like. Instead of the solid gel form, it should be a degenerated vitreous. So because of the liquefied state of the vitreous, it seeps through this retinal break and it collects as a subretinal fluid leading to detachment of the retina. So this is the gel-like vitreous body with liquefied vitreous posteriorly. Because of the dynamic eye movements, there is dynamic vitreoretinal traction exerted on the site of retinal degenerations or when predisposing factors are present. So because of the traction by this vitreous body, there occurs a retinal tear. And through this retinal tear, this liquefied vitreous, it gains access easily through the tear into the subretinal space and it separates the retina, a neurosensory retina from the retinal pigment epithelium. So this is the main pathogenesis of RRD. So what we understand from the pathogenesis is that if the vitreous gel is healthy and solid, then a detachment rarely occurs. If it is fluid and partially detached, then it drags upon the torn area and detachment can occur easily. So vitreoretinal traction is responsible for most cases of RRD. So this is the site of vitreous traction on the retina leading to retinal detachment. Coming to the clinical features. So there are prodromal symptoms like photopsia and floaters. So what does photopsia mean? It is the patient experiences flashes of light occurring in front of the eye. This is caused due to traction of the retina which irritates the neuroepithelium. And floaters, these are dark spots in the field of the vision. This is caused due to pigment dispersion in the degenerated vitreous. So these are prodromal symptoms, that is before the appearance of RRD. So after RRD has developed, what are the symptoms? The main symptom is localized relative loss of vision. If the detachment is localized to a particular area, then the patient will complain of loss of field of vision in that particular part. Whereas if the RRD is complete, then the patient says that he experiences a dark cloud in front of the eye, or a veil in front of the eye, or a dark curtain raising from up in front of the eye. And if it is sudden painless loss of vision, it is the most common cause of sudden painless loss of vision. So these are the pigment leading to the occurrence of floaters. So this is how the patient complains of floaters. See, you can see these are pigmented spots or dark spots present in the field of the vision. And this is flashes of light occurring in the field of the vision. This is because of irritation of the retina by vitreoretinal traction. And this is because of the pigment in the vitreous. So these are main prodromal symptoms, and the classical symptom after the occurrence of RD is appearance of a dark cloud or curtain or veil in front of the eye. Next, coming to examination. So on external examination, now the patient has come to you with a complaint of dark cloud in front of the eye. So how do you proceed with the patient? First we do slit lamp examination. So the routine examination of conjunctiva, cornea, irises, everything is normal. And in the pupil, you notice Marcus Gunn pupil or relative afferent pupillary defect. And IOP is lower than that of the fellow eye. And when we do plane mirror examination, that is distant direct ophthalmoscopy, we notice a gray reflex in the quadrant of detached retina. Coming to examination of the posterior segment. So we can examine the posterior segment with the help of indirect ophthalmoscopy, Goldman 3-mirror lens, or with the help of indirect slit lamp biomicroscopy. So first, what are the examination findings when we do indirect ophthalmoscopy? So the important finding is, instead of a red reflex, we see a gray reflex in the retina. Because the detached retina is opaque in color due to retinal edema, and also we cannot see the underlying choroid vasculature. So instead of the pinkish appearance, we have a gray colored retina, and there are undulations in the detached part of the retina. The folds, they show bright sheen at the summit, and at the sides of the depressions it is greenish gray in color, and they move with the movement of the eyeball. If the detachment is extensive, then we can see balloon-like folds. If the detachment is total detachment, then we see funnel-shaped retina with only attachment at the optic nerve head and another attachment at the ora serrata. So this is the procedure of indirect ophthalmoscopy. This is used for depressing the sclera. This is called scleral indentation technique, so that we can see the peripheral part of the retina up to the ora serrata, and we can easily identify the presence of any holes or tears. So this is the horseshoe shaped retinal tear you can see here, and this gray part is the detached retina. Here you can see clearly this is the detached retina, and the characteristic feature of RRD is occurrence of a hole along with undulations. And you can see the retinal vessels are tortuous cords extending over the detached retina. This is also another picture showing detached retina on the superior and nasal part, and the temporal and inferior part is normal. The other changes we see are, at the edge of the detached retina, there is pigmentary disturbance, and white spots of exudation, hemorrhages can also be present. Another important sign is Schaffer's sign or tobacco dusting. This is because of the pigment dispersion in the anterior vitreous. On slit lamp examination, we see in the anterior vitreous there is tobacco dust appearance. This is called Schaffer's sign. And other features, so all these are features of fresh RRD. And the coming to features of old RD, The main features are retinal atrophy, intraretinal cyst formation, and white line of demarcation or fixed folds. So this is a old RD. Here you can see intraretinal cyst formation. This is all the detached retina. And this is a demarcation line or watershed line. This is formed between the junction of attached retina and detached retina. It is associated with the pigmentation. And these are fixed retinal folds. So in comparative to the fresh RD, you cannot see undulations and wavy movements. Instead, the detached retina develops fixed folds and there is no movement of the RD with movement of the eye. This is also a demarcation line. And after examination of the fundus, we have to proceed with investigation. If in patients where the fundus is not visualized because of a dense cataract or dense vitreous hemorrhage, then we have to go for B scan or ultrasonography. So here you can see the detached retina is seen clearly. We see hyperechoic curve. Membrane is present anterior to the RCS complex, and this one is the PVD, posterior vitreous detachment, and this is detached retina. Coming to complications of RD. It can develop proliferative vitreoretinopathy. This is occurrence of cellular membranes in the vitreous. They can be graded into A, B, and C and D. And these they exert traction on the retina and result in recurrence of RRD. Other complications are complicated cataract, uveitis, and phthisis bulbar. So with that we complete the RRD, pathogenesis, predisposing factors, examination findings of old and fresh RD, and also the complications of RRD. So we have identified the case as rhegmatogenous RD. So how do you proceed with the management? So the main aim of the treatment of RD is to attain the opposition of choroid and retina. So how do we proceed with the case of RRD? First we must identify and seal the retinal breaks. After identification sealing of the retinal breaks, we have to release any vitreoretinal traction, and then we have to drain any subretinal fluid. After drainage of the subretinal fluid, there is flattening of the retina, so we must then maintain the chorioretinal opposition. So we'll discuss about each step in detail. So first step is identification of retinal holes. So how do you identify the retinal holes? Generally, these retinal tears are present in the peripheral retina. So as I discussed, retinal periphery can be visualized with the help of indirect ophthalmoscopy. So this is the technique of indirect ophthalmoscope. This is 20D lens and the patient is in supine position, and we can examine all the 4 quadrants of the retina up to the periphery, and ora serrata can be visualized by scleral indentation technique. So with this indirect ophthalmoscopy, we localize the retinal tears. So these are the types of retinal holes or tears. This is a horseshoe-shaped retinal tear. This is a round hole, and this is anterior dialysis of the retina. Dialysis means separation of the retina at the level of ora serrata. So after identification of the retinal tear, what we do is we have to seal the retinal tear. So how do we seal the retinal tear? There are 2 methods for performing sealing of the retinal tears. One is cryotherapy and the other one is laser. So both of these, they act by inducing chorioretinal asepsis and they help in sealing of the retinal tear. Cryotherapy, there is increased occurrence of PVR. So generally it is treatment of choice only when in very peripheral tears are located. Laser, it is associated with less morbidity, so it is the most common treatment of choice. So after sealing the retinal tears, so this is a picture showing laser performing sealing of the retinal tear. Around the retinal tear, we do laser in 2 to 3 rows so that there is opposition of the retinal tear. After sealing the tear, then we have to do drainage of the subretinal fluid. This can be done either by external sclerotomy room, that is with the help of a silicon tipped needle. We can enter from the sclera, choroid, and then into the retina, and we can drain the subretinal fluid. Or we can do the drainage of the subretinal fluid either from the internal procedure like pars plana vitrectomy. We can do retinotomy incision, and then we can drain the subretinal fluid. This is indicated in bullous detachments where chorioretinal apposition is difficult or when the marked elevation is required. The complications during this procedure are it can lead to choroidal hemorrhage, retinal perforation, retinal incarceration, and choroidal neovascularization and endophthalmitis. So after drainage of the subretinal fluid, because the retina gets flattened now, and now we have to maintain this chorioretinal apposition. So how do we maintain this chorioretinal apposition? This is achieved by two ways. One is from external method, that is called external tamponade by scleral buckling. Here we do inwards indentation of the sclera by applying a buckle so that the detached retina is maintains opposition to the retina choroid. This is achieved by placing a explant which is made up of either silicone rubber or silicone sponge, and it is sutured with the help of mattress suture. If the tear is isolated, then we place a radially implanted scleral explant, whereas if there are multiple retinal breaks in 2 to 3 quadrants, then we place a circumferential explant. So this is a picture showing scleral explant. This is the scleral explant placed beneath the extraocular muscle. Excuse me. So this is a scleral buckle. It causes indentation of the sclera internally so that the retinal tear is closed and opposition of the neurosensory retina to the RPE and choroid occurs. So first we have to seal the break, drain the SRF, and then place a scleral buckle. So this is a procedure of external tamponade. That is, we are applying pressure from outside so that chorioretinal opposition is maintained. So what is internal tamponade? It is done by pneumatic retinopexy. Here we inject either air or gas into the vitreous so that it aids in chorioretinal opposition. It is an OP based procedure and it is indicated only when the retinal detachment involves in the superior quadrant and it is involving less than 2 clock hours. So what kind of gas you inject here? We either prefer sulfur hexafluoride or chlorofluoropropane. So after sealing the breaks, this expanding gas bubble is injected into the vitreous and we ask the patient to position the head in such a way that chorioretinal opposition is maintained. And the patient should position his head in that particular position. Depending upon the location of the tear, the patient positions his head for up to 5 to 7 days so that the opposition remains in contact. The next is in patients with vitreoretinal tractions. So what we should do in patient with vitreoretinal traction? So first we have to start with pars plana vitrectomy, 3-pore pars plana vitrectomy. First we have to clear all the vitreous bands and we have to clear the edges of the retinal tear. After clearing the vitreous membranes, then we have to do drainage of the subretinal fluid either through the retinal tear or from a second retinotomy route. After drainage of the SRF, then we have to seal the retinal tear with endolaser. And then we have to maintain the chorioretinal opposition by injecting silicone oil or gas into the vitreous. So that is the procedure for patients in having vitreoretinal traction. So that is about rhegmatogenous RD. So the main predisposing factors are age of 40 to 60 years, males more common, myopes, aphakia and pseudophakia along with retinal degeneration, trauma, PVD. All these are risk factors for RRD. And pathogenesis after the occurrence of the tear because of the degenerated liquefied vitreous, it gains access through the retinal tear, and it separates the neurosensory retina from RPE. So that is the main pathogenesis. And clinical features with indirect ophthalmoscopy, we examine that a gray reflex is present and undulations are present, and movement of the there is movement of the undulations with the movement of the eye. In old RD, we see intraretinal cysts and demarcation line, fixed folds. All these are features of old RD. In B scan also, in patients with dense cataract, we prefer a B scan to identify the presence of RD. If the RD is total, then we have a funnel-shaped retinal detachment. And management, the main principles are: first we have to identify the bricks, then seal the brick, then we have to drain the SRF and maintain chorioretinal opposition either by scleral tamponade or with the help of pneumatic chorioretinal pexy. So that completes RRD. So the prognosis is, if the macula is involved, then the chances of regaining vision is lesser, and intervention must be done even before macula is threatened. If the reattachment is done within 1 week, it has better prognosis. So in which cases do we do prophylactic laser for the retinal tear? So all the predisposing factors, so anything is present, then we have to proceed with laser even prior to development of RD. So what are the predisposing factors? Trauma, myopia, degeneration, aphakia, pseudophakia. So all these are predisposing factors. In all these patients, we have to do Barras laser to the retinal tear. Next, coming to secondary RD. In secondary RD, I mentioned there are two types, tractional and exudative. So first we'll discuss about tractional RD, exudative RD. So exudative is also known as solid RD. So what is this type of RD here? The retina is pushed away either by any neoplasm or because of any accumulation of fluid. So what are the causes? It can be systemic and ocular. So systemic causes are toxemia of pregnancy, renal hypertension, blood dyscrasias, and polyarteritis nodosa. So coming to ocular causes, the ocular causes are congenital, like orbital optic disc pit, optic disc coloboma. All these can lead to exudative RD. Inflammations like orbital cellulitis, BKH, and sympathetic ophthalmitis. Vascular disorders like central serous retinopathy, neoplasms like retinoblastoma and malignant melanoma, or other causes like sudden hypotony, trauma, perforation of the globe, choroidal effusions. All these can lead to exudative RD. So coming to the clinical features. So this is similar to RRD. Here the detachment is also convex in shape. But in contrast to RRD, there I said there are undulations over the detached retina. But here the detachment is smooth, and we can see disturbed pattern of the retinal vessels because of the neovascularization of the tumor. And other hallmark of exudative RD is presence of shifting fluid. So what is the shifting fluid? Here the position of the detached retina changes with the change in the position of the head due to gravity. And on transillumination, we see transparency is present in simple RD, whereas in solid or exudative RD, the transillumination is opaque. And absence of photopsia, folds, undulations, and tears are characteristic of exudative RD. So how do you proceed with the treatment of exudative RD? The treatment is, we have to treat the underlying cause, like orbital cellulitis. If present, we have to treat the orbital cellulitis. Similarly, BKH, all these cases, the underlying cause must be treated. With the treatment of the underlying cause, generally, exudative RD resolves by itself. If there is any tumor like retinoblastoma or choroidal malignant melanoma, then we have to enucleate the blow. So this is the appearance of exudative RD. You can see multiple exudative retinal detachment, smooth and convex detachment is present. Next, coming to tractional RD. Here the retina is pulled away from its bed by contraction of the fibrous tissue in the vitreous. So what is the etiological factors? post-traumatic scar tissue. Because of retraction of the scar tissue, there can be occurrence of a retinal detachment. PDR, high risk characteristics, it can lead to RD, post-hemorrhagic retinitis proliferans, ROP, sickle cell retinopathy, plastic cyclitis, and proliferative retinopathy in Ehlers disease. All these are main causes of fractional RD. So what are the clinical features? So as I already mentioned, here you can see vitreoretinal bands, which are the main cause of traction. And in contrast to exudative and rhegmatogenous RT, here the detachment is concave and retinal mobility is reduced here. Tears and shifting fluid are characteristically absent in tractional RD. So the main treatment of tractional RD is we have to first release the vitreoretinal traction by pars-plana vitrectomy, and then we have to do internal tampering. So this is a tractional detachment of the retina caused due to vitreoretinal strands. This is also a picture of tractional RD. Here you can see this is a case of PDR. All these are new vessels and this is the detached retina. As I already mentioned here, undulations are absent and the detachment is shallow and concave in contrast to RRD where it is convex and with undulation. So this is also B scan. Here you can see a shallow detachment of the retina and this is the tractional band. So that is about RRD, exudative RD or solid retinal detachment and tractional retinal detachment. Retinal detachment, it can be a 4 marks question for you, or and generally RD is covered in all the MCQs for your PG entrance. Differences between RRD, exudative RD, tractional RD, you must know perfectly. All these can be questions for you, short and very short. Essay does not come from RD, but short and very short comes from RD. So next we'll proceed with RP or retinitis pigmentosa. So what is RP? It is a group of hereditary retinal dystrophies. Initially and predominantly it affects the rod photoreceptor cells, but later there is subsequent degeneration of the cones as well. And it is the most common hereditary fundus dystrophy. So first rods are involved and later cones are also involved. So it is a rod cone dystrophy. It is the most common hereditary fundus dystrophy. That is a PG bit for you. Coming to the incidence. The worldwide incidence is 1 in 5,000. And age, it appears in the childhood and progresses slowly, resulting in blindness in the advanced middle age group. Race, no race is known to be exempt or more prone to RP. Males, it is more common than females with a ratio of 3:2. And the disease is almost invariably bilateral. Initially, in some patients, one eye is affected, but later both eyes are equally affected. Coming to inheritance, RP can occur as either a sporadic disorder or inherited disorder. Sporadic disorder means only one member of the family is involved and there is no previous family history of RP. This is because of mutations of many genes including the rhodopsin gene. So this is also known as simplex disorder. It is the most common variant. Up to 40 to 50% of the cases of RP are of sporadic onset and it has the best prognosis. Coming to inherited disorder, also known as multiflex. It can be either autosomal recessive, autosomal dominant, and X-linked recessive. Autosomal recessive constitutes about 20% of the cases and it has a better prognosis. Autosomal dominant about 25 to 30% of the cases and it also carries a better prognosis. Whereas X-linked recessive, it constitutes only 10% of the cases and has worst prognosis. And RP can be classified into 2 types. Massoff and Finkelstein has classified it into 2 types, type 1 RP and type 2 RP. So what is type 1 RP? This is childhood onset night blindness. Here rods are more affected when compared to cones and that it progresses early. Whereas in type 2 RP, it is adult onset night blindness. Here rods and cones both are involved. Coming to clinical features of retinitis pigmentosa. The main important feature is night blindness. This occurs even prior to occurrence of the changes in the fundus. This is because of degeneration of the rods. Other feature is dark adaptation is delayed. The light threshold of the peripheral retina is increased in the initial stages, and in the late stages, the process of dark adaptation itself is effective. Coming to important characteristic finding is visual field loss. Initially, the peripheral field of vision is lost, and later the patient becomes symptomatic only when the peripheral field of significant amount is only lost and the patient reaches the only tunnel vision. So this is the normal visual field of a person, and this is the visual field of a person with RP. Initially peripheral field is lost, but later it extends both anteriorly and posteriorly until only a central part of the vision is left behind. So this is called tunnel vision. This is an important feature of RP. So those are the symptoms of a patient with retinitis pigmentosa. The main important feature is night blindness, and other features are delayed dark adaptation and visual field changes. Coming to examination findings. So what you see in the fundus, on the fundus examination, the important finding is bone spicule intraretinal pigment. This intraretinal bone spicule pigment, how is it formed? It is formed because of migration of the pigment into the retina from disintegrated RPE cells, and this accumulates in the interstitial spaces surrounding the retinal vessels. So RPE cells, they get degenerated, and the pigment from this, it gets migrated and settles in the interstitial spaces surrounding the retinal vessels. So the pigmentation is typically perivascular and bone spicule appearance is present. Initially, these changes, they are found in the equatorial region, and later it extends both anteriorly as well as posteriorly. So this is the pigment you see. Bone corpuscular pigment present along the vessels. Initially, it is present in the mid-periphery. Other important feature is optic atrophy. Consecutive optic atrophy is present, so the disc becomes waxy yellow in color. The other features are attenuation of the retinal arterioles, thinning and atrophy of the RPE in the mid and far peripheral retina, and relative preservation of the RPE in the macula is an important feature of RP. So the 5 important changes in the fundus are bone spicule pigmentation in the along the vessels. Second one is optic atrophy, waxy pallor of the disc is present. Third thing is attenuation of the retinal arterioles. RPE atrophy is present. And RPE in the macula is preserved until late stages. So first 3 findings, that is bone spicule corpuscular pigmentation, optic atrophy, and attenuation of the arterioles. These 3 are the characteristic triad of RP. So that is the examination findings. So next we proceed with investigation. So what investigation we do? We do Goldman perimetry. That is for observing the visual field changes. As already mentioned, initially there is a arcuate scotoma in the mid-periphery. Later it extends anteriorly and posteriorly. Only tubular vision is left behind. Coming to electrophysiological tests. ERG, that is electroretinogram. Initially the B wave is subnormal and later it gets completely extinguished. Coming to EOG, it is subnormal with absence of light peak. What are the ocular associations with RP? The important ocular associations are myopia, keratoconus, primary open-angle glaucoma, and microphthalmos, and posterior subcapsular opacities. So again, this is a fundus picture. For your easy understanding, here I have given a picture of normal fundus, and this is the picture showing retinitis pigmentosa. So this here first we'll see, compare the optic disc. Here optic disc color is healthy and pink in color. Here the optic disc is pale, waxy yellow in color. Coming to arteries, here you can see this is the normal caliber of the vessels. In contrast, here the retinal arteries are very thin and attenuated. The other characteristic finding is appearance of retinal pigmentation. So these three is the classical triad of RP. Coming to syndromes associated with RP, the main syndromes are Usher syndrome, Kearns-Sayre syndrome, Basin-Conwick syndrome, Refsum syndrome, Bardet-Biedl syndrome. These syndromes, they can be given in your PG entrance exam, but for UG exam, it is not required. So I have not mentioned all the features of these syndromes. Coming to atypical RP. So atypical RP means instead of the typical triad, here only some features are present and some features are absent. So that is called atypical RP. So what are the types of atypical RP? We know retinitis pigmentosa, sign pigmento, retinitis punctata albicans, sectoral RP, and pericentric RP. So what is retinitis pigmentosa, sign pigmento? Here there is optic atrophy and attenuation of the retinal vessels. But what we lack here is retinal pigmentation. So retinitis pigmentosa, sign pigmento means all of the features of RP are present except the bone corpuscular pigmentation. Next type of atypical RP is retinitis punctata albicans. So here you can see the instead of black pigmentation, you see whitish dots around in the mid periphery of the retina. So that is called albicans, means white. So these dots, they are instead of black color, they are white in color. That is called retinitis punctata albicans. Other variant is sectoral RP. Instead of presence of the RP in the mid periphery and extending over the total fundus, here the RP is localized only to one part of the retina. And pericentric RP is another variant. Pericentric RP is in contrary to the RP where macula is spared until late stages. In pericentric RP, first the part of the retina surrounding the macular region is involved. Next, coming to treatment. So there is no cure for retinitis pigmentosa. So what we have to do for arresting the progression? A patient has come with you with RP in early childhood. So what we do? There is no cure for RP, but can we arrest the progression of RP? There are various studies saying that by implementation or supplementation of vitamin A, it can progress or delay the progression of disease. So vitamin A, about 15,000 international units per day can be given, which reduces the progression of the disease. So how do you treat a patient with RP? Gene therapy, all these are under research. Gene therapy, that is by introducing a healthy gene into retina. Transplant research, by transplanting the degenerated retina with healthy retina. Retinal prosthesis, here we implant light sensitive electrode into the eye. This is called bionic eye, and this is being practiced in the American countries and in patients where there is only perception of light. With the help of this bionic eye, we can gain vision up to 3/60. So it helps in relatively improving the quality of the life. And other important feature or treatment modality which we give is to improve the quality of the life. So how do we improve the field of the vision of the patient? By prescribing low vision aids. And we have to advise the patient to rearrange the furniture so that he reduces the risk of stumbling or bumping into the things. And other important thing is genetic counseling. We should advise the patient not to beget children, and also we have to discourage the consanguineous marriages in this family so that there will be decrease in the incidence of RP in the further generations. So that is about RP. We have to mainly remember the classical triad of RP and the various types of inheritance of RP and visual field and characteristic symptoms. And in treatment, only the research part is important. Vitamin A supplementation helps in decreasing the progression of the RP. So with this, we complete retinal detachment and retinitis pigmentosa. I hope I'm clear with everything. If you have any doubts, you can ask me. Does retinal detachment occur if a myopic patient watches computer screen or cell phone screen for a long time? Actually, that does not influence anything. Occurrence of retinal detachment is not associated with more screen time. In pathological myopia, there is occurrence of retinal degenerations more in the periphery. So that acts as a predisposing factor for occurrence of retinal tear. Increased screen time is not associated with retinal detachment. Any more questions? So if you don't have questions, shall I give you a quick session of asking questions from the previous class? We have just 3 minutes time, so I'll just ask some few questions, only 5 to 6 questions I'll ask you. So what is Salu's sign? What is Salu's sign? Okay, 75, please answer. 75, you can type your answer in the chat box down there. S-shaped deflection, where do you see this Salu's sign? In which stage of hypertensive retinopathy do you see Salu's sign? Deflection of the veins at the AV crossings, stage 2. Benign, okay, so you mean chronic hypertension. Okay, very good, very good. In which stage do you see silver wiring of the blood vessels? It is which grade of the arteriosclerosis you see silver wiring of the blood vessels? Yes. Okay, very good. And about ROP. Tell me the stages of ROP. Acute stage of ROP, how do you classify ROP? I know it is a big question to type out for you. But in ROP, that is the important thing. Okay, tell me what is the stage 3 of ROP. That will be easy for you to type. Instead of typing all the 5 stages, tell me what is stage 3 of ROP. Shall I pick up any number? Let's see. Number 60. Registration number 60, 7060. Are you there? Okay. Retinal fibrovascular proliferation introductions. Okay. So what is rush disease? Okay. Very good. 87, 73, 102, all very good. And what is rush disease? Aggressive posterior ROP. Okay. What is the main pathogenesis of ROP? Why does it occur in premature infants? What is the main pathogenesis of ROP? Why not in normal infants and only in premature infants? Why? So this is the last question. With this, I'll stop today's class. What is the pathogenesis? VEGF is down-regulated. VEGF is down-regulated by the oxygen we supply, but mainly avascular zone is present. The peripheral part of the retina is not vascularized in premature individuals, infants. So nasal retina, it completes by 8th month, whereas temporal 1 month after gestation. So nasal retina is also not vascularized in these premature infants, and when we supply with oxygen, it is more prone for ROP. Okay. So I think at least some of them are reading after my class. So I'm happy with that. I hope you all understood today's topic. So in the next class, I'll discuss about retinoblastoma and other important topics like central serous retinopathy, CME, and ARMD, and a small notes on important topics in vitreous. Okay, so if you don't have any questions from today's topic, I'll just sign off. So no questions for today. No doubts. Okay, thank you. We'll meet on Wednesday.